started. We have a pretty full program today. I'm Roy Herbst from Hematology Oncology, the Cancer Center. And I thought we'd start by saying a few words about the Iris Fisher Lectureship, which is endowed by David Fisher in 1999. And I know that their daughters, Francie and Karen, are online with their spouses and their grandchildren. And we'd certainly welcome you to come in future years. David passed away this year or last year, so he's not here. But I remember over the last 14 years sitting in the front row, hearing him introduce this lecture and realizing how important it was to him. On the next slide, you can see David. He was involved with the Yale School of Medicine for nearly 60 years. He was the first medical oncologist in the New Haven community, though sometimes people debated that, and he remained in private practice for 30 years before joining Yale Cancer Center in 1993 as a volunteer and full-time in 1995. This fellow as a volunteer did more than many of the faculty who we paid. He chaired and co-chaired the Cancer Committee for Yale Cancer Center, Yale New Haven Hospital since 1997. And among his other things, he was very involved with hospice. He was on the board of Connecticut Hospice. He also won the 2020 Yale Cancer Center Lifetime Achievement Award. You can see from these pictures, you can see he was a stalwart in the Jewish community on the left. You can see him with some of the kids and wearing his Yale hat. And especially important for me is when I first came here, I said to David, we need to emphasize education and teaching. And David actually sponsored, and to this day, we give out the David Fisher Awards in hematology and oncology for teaching and mentorship. And you can see David, that's about 8-9 years ago. These lectures, as I say, have been extraordinary, and you'll hear about today's speaker, who's amazing. Quality of life issues held more than a professional interest for David. These issues are a personal concern for him and his wife, Iris. And this is actually the lecture he dedicated in her honor, who was a brilliant concert pianist. I'm sorry I never heard her play, but I had been to David's house a few times, so I did see pictures. And she was diagnosed with sarcoidosis, which is, of course, a very painful and incurable disease of the heart and lungs. The couple's treatment decisions were weighed and balanced against the impact of therapies that they would have on her personal well-being. Hence his desire for this lecture. And this is like the 20th lecture. It even went on through COVID. Dr. Fisher's hope was that this lectureship would serve as a lasting memorial to his wife, Iris, while providing an educational opportunity for our physicians and staff for the benefit of our patients at the Cancer Center. Both are missed. David, we miss you enormously. Your wonderful presence. You cared about the patient. You're a brilliant clinician and scientist. So we're thinking of you today. And now I'm going to turn this over to Laura Morrison to introduce today's speaker.
All right. Hi, everyone, and welcome to Smilo Grand Rounds today. I'm privileged with my colleague Jen Capo to introduce our guest speaker. I am one of the hospice and palliative medicine doctors here at Yale. I serve as an attending on the York Street campus, and I direct our palliative medicine education program. And within that, direct our Yale Serious Illness Communication Program. And Jen Capo is our Chief of Palliative Care. Dr. Bach is our guest speaker today. Tony Bach has been a mentor to both of us for over a decade, even in developing our program here at Yale. He's an internationally renowned palliative care specialist, an innovator, and researcher. He is currently a professor of medicine at the University of Washington, where he is also a board-certified oncologist and palliative care specialist. On the innovation front, he is best known for being a co-founder of what's called Vital Talk. Vital Talk is a national nonprofit that was founded to further serious illness communication and make it more accessible and of higher quality for our patients and their families. What's unique about the model is really creating a skill set that can be both taught and learned and disseminated widely, internationally and nationally. And I think what I wanted to share that I appreciate the most really about the innovative model that Dr. Bach and his co-founders created was really the spirit of curiosity and drawing upon expertise from many peripheral fields, even the startup environment that's so rich in the Bay Area, but also from K through 12 education, the literature of psychology, specifically adult learning theory, the field of mindfulness, and the science of communication. And I think it's just something for us all to really appreciate and carry forward.
Great. And I just wanted to share one small example of how Dr. Bach actually has influenced the Yale Palliative Care Program. Back in 2010, when I was being recruited by Tom Lynch, who was the Cancer Center director at that time, Dr. Lynch asked me to envision what Yale palliative medicine could be with the right vision and the right mission. And I'd happened at that time where I received this request to be at a retreat for rising leaders of the palliative care field. In fact, Andrew Putnam and Laura Morrison were with me at that retreat. And I happened to be assigned to Tony Bach as a mentee. And he graciously spent over an hour walking around this beautiful lake in Illinois, talking to me about what Yale palliative care could be. And after that meeting, I knew that this was going to be an amazing opportunity. So it's partially, probably really importantly, due to that conversation that I experienced with Dr. Bach that I came here. And I've had this amazing last 15 years interacting with all of you and having the chance to grow palliative care here with this amazing interdisciplinary team with whom I work. So thank you. We're grateful. We're so thrilled you're here and looking forward to your talk.
Well, thank you so much. Can you guys hear me? Okay. While we get our slide switched, I'm going to do two things. I would like you to first turn to the person next to you, and if you don't know them, introduce them yourself. Or if you do know them, say hello and have a quick check-in. And then the second thing is, can you spend a moment then remembering one of your teachers, one of the people who taught you something important about communication? So go forward and I will be back with you in about a minute. Thank you.
I'll let you do the honors there.
Thank you, everybody. Thank you. Thank you for coming and starting in kind of an untraditional way. One of the things I am interested in, especially now that we can get back together, is what makes something worth coming to in person, right? And I would propose that part of the ritual of coming together for a discussion about how do we practice, how do we improve, how do we reflect on what we're doing, is actually seeing your community and being together. And I think it's one of the things that we kind of lost during COVID that we are now rebuilding. So thank you for doing that. I'm just curious, of those of you who thought about someone from whom you learned something important about communication, for how many of you was it a patient? Can you raise your hand? A few. How many was it a mentor? How many was it someone else, a family member or a friend or something like that? Well, thank you, because I think what that shows is how we learn to relate to each other is actually a combination of many things. It's not just a skill set. It's not just something you learn online and learn on an app. It's actually you learn in a relational context. And so that's one of the things I'm going to be coming back to today. Here's my title slide. And so my title slide, disclosures. I don't have any formal disclosures, but I will just say that this title slide I created using AI. Just in the spirit of this talk. And you'll notice it's a little bit too much and a little bit not enough all at the same time, right? I asked for an Asian doctor and I said, I got this, and I said, actually, I think I need someone older. And it made me look way too old. And so I went back to this. But, these days, you can go to ChatGPT and go, can you write me a talk? And if you want to do this, you can look at all the stuff it's scraped from all the stuff that I put in the medical literature, and you could probably get something from it. But what AI can't do, what it cannot do, is it cannot meet this moment. right? And we are meeting today at a very distinctive moment in the history of our country and the history of medicine. And just to channel Dr. Sherwin Newland, Shep Newland, who's part of the reason that I am here, he, in reviewing an amazing book called The Spirit Catches You and It Falls Down in the New Republic back in 1997, he said, the challenge as a doctor, he's talking about, is to respond to a reality whose enormous consequences are too often underestimated or ignored. Patients bring to doctors not only their diseases, but their entire lives. And so by channeling Shep, I'd like to just put out here that what we are doing in medicine right this moment is we are still responding to this challenge, right? And the challenge changes every time new technology comes in, and that's partly what we're doing now. But what I want to step back to is, like, as we think about why we are communicating and what we are here to do, it is so easy to look at what is happening now, the slash and burn politics of what is happening, the undercutting of the NIH, and to think, wait a minute, is medicine just a business? And actually, the reality is, it is not a business. Medicine is a public good, right? There are economics to medicine. We need to fund it. We need to make it sustainable. We need to make it possible for all of you to spend the time with patients that they deserve and that you deserve to do the best job that you could. But the reality is, that is not part of a business plan that we can just by pushing people onto AI to order their exams for themselves, right? Like, we could get to the point where they could order a CT scan through their app or whatever, but actually that is not the kind of medicine that I would wager that any of us would want to practice. You know, when I was starting my career, this was a while ago, 1984, you know, one of the reigning new kinds of thinking was actually by a Yalie. This was Dr. Jay Katz. He was a physician and a lawyer here at Yale, and he wrote an incredibly influential book, The Silent World of Doctor and Patient, which actually still stands as a milestone in the field about how patients behave and how doctors behave together. And the silent world he was talking about was a kind of silence where patients didn't really say what they thought. Doctors said everything that they thought, and there was a kind of silence in between them. And part of his innovation was to say, at the level of ethics, at the level of someone in the field, that we should actually break this open, that we should expose this whole conversation to real air. And he was an innovator in his time. Of course, he was an academic, right? And so this was happening in the halls of academia. Outside, the same year, right? This was the year I graduated from medical school as a young gay man. This was happening, right? We were in the middle of the AIDS epidemic. People my age were dying left and right. I was watching patients in my medical school being treated like, honestly, like specimens at the zoo. They would come into derm clinic and we would all parade by and stare at their Kaposi sarcoma and make, you know, snotty jokes in the hallway about how they had gotten it. But what these guys taught us is that it is not okay just to sit down and wait for other people to help you, right? I, as a gay man in that time, I can tell you that the situation looked pretty bleak. It was pretty obvious the government wasn't going to help us. It was pretty obvious pharma wasn't going to help us. What were we to do? And the fact was, it took a whole series of kinds of public action and articulation of what was needed and creation of whole new models of care that included hospice, that included palliative care. And so in many ways, my career was developed in the crucible of like one of the most devastating epidemics of our time. And the lessons here from what they did as social change agents is still with us, and I'm here to remind you about them today because we still need them. We need them now more than ever, right? The public good of medicine actually isn't something that lives in the insurance companies. It's not something that lives in the libraries or the internet. It lives in community. the public good of what medicine means lives here in this community. And that's why I asked you to introduce yourself or catch up with each other. That's why I asked you who else in your life had really influenced you, because you are all part of these big communities that create ideas and standards and practices about what it means to care for each other, right? And I learned that from a whole bunch of gay men who actually died and gave their lives for this moment. They didn't have anything, but they had community. And it was a really powerful lesson for me that I did not expect, because I thought, well, they don't have Ivy League degrees. They don't have experience. They don't know how the system works. But here's what happened is they learned how the system works. They got onto the NIH study sections. They got onto the front page of the New York Times. And by doing that, that multi-pronged approach that was a part of social change at the time, that changed the world. And it changed how we practice medicine today, right? That's not the only kind of community. Here's the community around a woman who had breast cancer, Jennifer Marandino. This is her rowing community that she created after she was diagnosed with a really serious breast cancer. And I'll get back to her later, because this is the community of people that you don't see who are behind every one of the patients who walk into your office, right? And then here's the community of us, right? One of the things we learned when we were creating Vital Talk was that we needed our own community of clinicians. And so this is people in Europe and Australia and Japan. This guy translated our book. But just to show that a key part of what we were doing was we were not just creating skills to tell people what to do. Like, nobody wants to do that, right? You guys don't want to be told what to do. What is really powerful is a community of practice that creates and develops better ways of doing what we all do, because we all own it, we all share it, and we all use it, right? So what do I mean by a sense of community? And I will get to the communication part of here in a minute. Community is not just a bunch of people together. Community is a sense of belonging. You are part of a community to the degree that you feel like you belong. And actually, in this atomized age of internet and apps and TikTok and Tinder, right? Like swipe left, swipe right. Pretty soon we're going to be selecting doctors like that, right? The way that you feel like you belong turns out is going to be a really big ticket item. And my prediction is, after the attention economy, that is what we're in now, everyone's fighting for your attention, it's going to be the belonging economy. Who do you feel connected to, and who do you care about? This is Jennifer, the day she was diagnosed, right? This was quite a while ago. Her husband, Angelo Marandino, is a photographer who lived in New York City at the time. And she was diagnosed in 2007 with breast cancer. It metastasized just 2 years later, and she died a year and a half after that. I mean, this was the old days of breast cancer. And they decided to document her journey and publish all the photos publicly in a way that had never been done before, because they wanted to open up the experience of people living with a serious illness. And so I'll show you some of his photographs, and they are quite remarkable. And as you can see, this is not an AI creation, right? There is something in her presence and how he's captured it that makes her predicament as a person living with a serious illness immediately palpable, right? And of course, this is the pre-iPhone, pre-selfie days. He was documenting her experience in a way that actually was starting to teach everybody, teach all of us, what it meant to really live with a serious illness, right? And, as a young woman who's facing something that she didn't really want to face, who knew how all this would unfold? And I will say that one of the things that you don't see here in these pictures is how the breast cancer activists who took over the development of what breast cancer therapy has become, they actually took lessons from the AIDS activists. And the reason they took lessons from them was to find out how to make their voices known how to collaborate with the medical establishment, how to get funding for breast cancer research. And here we are, 20 years later, and the outlook for people with metastatic breast cancer is actually entirely different. And it's entirely different because of people like this, right? And he was an artist who was doing his part, but what it did was all of a sudden the stigma around cancer was, these were days when nobody told each other they had cancer, when the doctors didn't even always tell you you had cancer. Like, this was the kind of pioneering work that helped all of us create the need and the importance of talking frankly with the people that we work with. I was talking with Dr. Billingsley, who's an old friend of mine. We actually sat in a whole lot of tumor boards in the Seattle VA back in the day. And I asked him, was there something he wanted me to bring up? And the thing that he mentioned was trust, right? And I think it's something we are all struggling with, right? Like, what's happened all of a sudden? I feel like I've woken up 20 years later and nobody trusts me. Well, I want to turn to this theorist, Nicholas Lerman, who wrote about trust and power and the reciprocal relationship of them, because this philosopher's point is that complete information is unattainable, right? You could just never have that as a decision maker. What has happened in the world is that trust is the mechanism by which individuals willingly reduce uncertainty and risk. I put my trust in Dr. Billingsley because I think he is a guy who could do a surgery that would genuinely help me. And I don't know every detail about the surgery, and I don't even know that much about him, but I trust him. I'm willing to put my trust in him. And his power to be legitimate has to be underpinned by trust. And so there is a direct relationship between trust and power in these environments that we live in, right? We have a lot of power. They have to meet us with trust. But the issue is that the complexity of what we are doing now has ramped up so much that actually the people that we are serving are getting lots of different kinds of information everywhere. The complexity of what we do makes it difficult for us to be completely transparent. And so all of a sudden, this trust and power relationship is breaking down, right? Think back to a time 50 years ago when you were William Carlos Williams driving around in your sedan, writing poems in between patients and giving pain medicine to the occasional person out of your bag where your entire pharmacy was in your black bag, right? There was a kind of transparency there that was radically possible, which meant that your patients would pay you in chickens or eggs or dollars, whatever they had, and you would just roll with that, right? And because you were that person's physician for a lifetime, there was kind of this unspoken thing about, yeah, I trust you. And you knew that. You had seen him at your house. You knew he would come back. All your neighbors knew him. We're in a different world now, right? And so we have patients who are now trying to figure out the best treatments for themselves. They are on peer-to-peer networks. They are reading things. And what this has kind of led to is a real questioning of what is the expertise that we all have. Do we really know what we're talking about, right? And so this book, which started from an essay in Politico, actually really gets at the sociology of what is happening to experts now. And you're seeing it right here, right? This is a self-styled doctor who's giving advice about vaccines and saying so much science is now bought, right? And people are looking at this and believing it. And what it is resulting is this, right? Unvaxxed, unafraid. I mean, it seems preposterous, right? But in fact, this is happening in our government, right? So I just say that to mean that the environment that we are operating in has radically shifted. And when you are now communicating with people, you actually have to think of different levels. There's the communication at the level of the person you are sitting with in clinic. There's the communication of the level of your colleagues and peers, right? And then there's the level of actually our interactions as a profession with the public. And I would submit that that is a way in which we are now challenged in our communication to work at all of those levels, because actually, if we aren't responsible for them, we're just going to get more of this, right? Technology is upending us. And I feel like, one of the things about AI is, yes, it's going to be our great savior. It'll save us time in clinic. We can just look at our phones and type questions in when we don't know something, and the patient will just sit there and wait patiently for us. I'm not sure what's supposed to happen there, but the idea is, are they just going to replace us? Are people just going to be getting all their cancer care from apps and then ordering CT scans by themselves? I would just submit that technology has upended medicine before. This is part of an old pattern that we have seen a number of times, and that we communicators, people who care about the relationships that we have with the people that we are working with, honestly have struggled with over the years, right? And here, just to go back to Jen and her story for a minute, Eduardo Breer and another international group of experts looked at and tried to map out the illness trajectories of incurable solid tumors, right? Here's the old story, right? You were good for a while and then you declined. And if you had some kind of good treatment, it would push out the curve a little bit, right? That was the classic kind of mental model that we had and continue to have for many kinds of incurable cancer. But actually, now there's some other things that are totally different. What happens when somebody starts to decline, gets targeted therapy, or gets a liver resection, right? And then actually their function and quality of life bumps back up for a while, and they feel like they are as good as new and are going, and then start to decline. That's a cultural experience that we have no benchmarks for, and that patients are struggling with, because they come to you and to me and say, well, I won the lottery and the medicine worked and I got more time, and now I'm not sure what I should be doing, right? I am doing this study with psilocybin for people with metastatic cancer, and this is the thing that I am hearing over and over. Well, yeah, it worked, and now what, right? They're really not sure. Here's another kind of trajectory, immunotherapy. It keeps you going, but kind of at a different level. And then there are all these side effects, all this autoimmune stuff, all this stuff you have to do with their diet. So actually, this is a way in which the complexity of what we are seeing in terms of clinical trajectories has complexified in a way that makes it much more difficult for us to be very certain with our predictions, or to be reassuring that we know what's going to happen next. It's super hard, right? And actually, our indecision or our ambiguity or uncertainty is often seized upon as a problem. It's often seen as a reason that we don't possess the expertise that we really do. So what I'm saying is actually our job got a little more complicated with all this new anti-cancer technology. And actually that's a good problem, but it's a new problem of the situation we're in. I mentioned cancer on the internet. This is the American Cancer Society. I love this, user beware, right? Then there's this whole thing about finding out about your CAT scan results even before you go to your clinic, right? Everybody's looking them up online and then doing massive Google searching and then coming to you. I think that has totally changed the dynamic of what happens in clinics. And we haven't really figured out how to adjust to it. And because the funding for these kinds of studies is just, far different than other kinds of studies, honestly, I think we're still struggling to know what the best practices are. But what I will tell you is that the effect is quite big. And just to illustrate that, I'm going to go back to an old study I did about patients who wanted to have physician-assisted suicide. This was in Washington State, before physician-assisted suicide or death with dignity was legal anywhere. And we did these longitudinal interviews with patients and patients who were looking for physician-assisted suicide and their families. And one of them actually really changed me. It was the partner of a gay man who had advanced HIV before the antiretrovirals, ended up dying. And the partner recounted a last meeting with the doctor, where the doctor was talking to him about his intractable thrush. I mean, you guys probably, the younger of you probably can't even imagine this, but there was intractable thrush, and it actually would lead, it was one of the last things that happened to people with advanced HIV. And the quote there, our doctor was like, you do not want to die of thrush. And basically he said the thrush would grow and shut off your esophagus so you wouldn't be able to swallow. My partner would drool constantly and end up starving to death the doctor said, you don't want to die like that. And that is the moment when he decided to do a hastened death, right? Because the doctor didn't have a better way of approaching this issue of what happens when the illness gets really bad or what happens when the illness gets worse. This was actually the anecdote that made me think that there was something much bigger to communication that we all needed to understand. And you know what? This problem, this technology issue is not over. This is the proportion, this is the number of medical assistance in dying deaths in Canada, where both physician-assisted suicide and euthanasia are both legal. And you will see that in Canada, as in the other countries where euthanasia has been legalized, the incidence of use is just going up, 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 up. And I don't know that this is necessarily a bad thing. I feel quite torn about these practices. But what I can say is I think part of this reflects how we talk to and deal with and communicate with people about what they're facing. Because it's when they feel like we don't have anything more, you got nothing, that's when they go, yep, this is the way I'm going to do this. So I think this is another kind of cautionary tale about a new kind of technology. My last cautionary tale is here. You guys know this EPIC, I'm right? Yale Cancer Center uses EPIC. I'm just going to compare AI as an example to the introduction of the electronic medical record. Like, how many of you are old enough to remember when we just wrote notes and charts? I know. Yeah. Well, so the electronic medical record was supposed to solve all our problems, right? You never had to go, wait, that volume of the chart hasn't been found, right? You wouldn't have to suffer through your colleague's horrible handwriting, right? All the meds would be in a nice list. The technology was going to solve all of that, right? Well, what happened? Well, actually, I would submit the technology has been co-opted by forces that think that the reason for your existence is to bill. And the entire system is designed around maximal efficient billing. That doesn't leave a lot of space for the other stuff that you want. So for example, when I read the chart now, I'm like, what is happening with information? Because I feel like I'm reading like 85%, cut and paste. And I feel like in my own mind, I'm back into an oral culture of medicine where I only know what's happened if I talk to another person who actually saw the patient, right? Because you can't tell from the chart. So I just mentioned this as a way that saying that technology is not automatically going to make us better, and that we, as the clinicians and people who are using it, need to be involved in a different way with AI than we were involved with electronic medical records. Here's the study that really got palliative care put on the map. This is Jennifer Temmel's study of people with metastatic non-small lung cancer, now kind of old, a little dated even, she would say. The treatments aren't the same. But what it showed was that patients who had early palliative care had better depression symptoms, better anxiety symptoms, and a better PHQ-9. So those are all measures of mood. And they actually lived longer. And what I would submit is that this improved mood and symptom control happened because of a multi-phase communication process. I was part of the team that helped Jennifer analyze all the notes from that study, that very first study. And what we saw was that, in the beginning, there was a lot of stuff about, relationship, discussing the cancer treatment, illness understanding. The real decision-making came much later. And what that says to me is that when you are working with a patient, the communication that you do is completely contextualized to the moment that you are in with that cancer. And the moment that they are in is as much about their mindset as about what you were reading in the chart about their Signatera or whatever prognostic thing that you are using these days. The nuts and bolts of this, there's some fabulous people here, Jen and Laura and others, who will actually take you through the kinds of experiences that you actually need to get this under your belt. But what I'm saying, I am just showing this to say that there is a fair amount of data that shows how communication actually has a real influence on the kinds of medical outcomes that we would call solid medical outcomes. And of course, more technology, telehealth versus in-person, it turns out telehealth is pretty good. It turns out you can do a great deal of this work on Zoom. Who knew, right? But what this also showed was that there was a difference in the rate of hospice referrals at the end of life. And so there are some decisions where it looks like there is some intangible quality of being together in person. And one of the reasons I'm so grateful to all of you for coming today in line, because I don't go to grand rounds very much either, honestly, is there is an intangible quality of being here together and having a common experience and walking out of the room after lunch and going, what did you think about that guy, right? It's part of the whole ritual, but it's also part of what helps us process what we're dealing with here. So the other thing that I would want to say from summarizing all the research is communication works as a recursive process, right? There is this thing you are doing with information. There are ways patients are participating, and you go back and forth and around, and you influence each other. And what I would say is that there are trainees who ask me, well, what about when the patient says such and such? I can't do my skills protocol or whatever, or I wanted to get to this and I couldn't. And what I would say is, that's part of this process that you are in, and the way that you adapt yourself and adapt this communication to what they are after, what they need, the things that they need that they can ask for, and the things that they can't ask for, right? That they are too embarrassed to ask for, too ashamed to ask for, too whatever. Those are the ways in which you make this process really go. Will machines be as good as this as we are? Right, that's kind of the AI question, right? Like now you can have a chat bot that does your therapy and you can text in the middle of the night and all that stuff. And there's some data that suggests that teenagers use the text in the middle of the night and they're texting their chat bot at 3 a.m. to say, I feel like, cutting myself. What do I think about that? What I want to take you to is a little bit of background about how physicians think and behave. And so this is some research that we did with a group that actually does interviews with physicians where they ask them to bring in images. And these images are actually all images that physicians brought in response to a question about, what does palliative care mean to you? What are you trying to do? And I mean this as a sense of like describing the landscape of where you are. So these people said, I have to tell people the right information and path. It is so confusing. I feel like I am the guidepost here, right? My job is to be informational. My rules are based on objective data, right? I am trying to be systematic. I am looking for the protocol. I am looking for guidelines, right? And they don't allow themselves to make mistakes, right? It's been hammered into us, right? That if you fail, it is your fault. So you have to be at the top of your game and you have to be perfect. And that kind of perfectionism has rolled into a whole syndrome of physician well-being, or on the flip side, physician depression that has resulted over decades in physicians having the highest suicide rate of any white-collar profession, right? So there is a cost to this, and there is a reason for you to keep an eye on this, right? And then, and this is part of how we physicians manage the complexity of the information that we're dealing with, is that we rely on algorithms to get the best care. In cardiology and in oncology, we use algorithmic guidelines, we use judgments. And that, to my mind, is not only a way of creating best practices, but it's a way of reducing the complexity. Because if there's too much complexity, you just actually can't function because there's so many details and so many things to remember. So in all that, I'm going to show you one last picture of Jen. This is the first picture in Angelo's book. And he now lives in Cleveland, but he gave me permission to use his photographs when I was talking to other clinicians to just remind us and remind me to talk about the fact that amidst all these algorithms, there are many sides of people that you will never see in clinic that in fact are at the core of them. Yeah, when we are talking to them, can we be as empathic as a chat bot, right? You guys probably saw this thing. It's about how chatbots are more empathic than physicians, and their responses were rated as more empathic. And what do I think about that? Well, here's what I would say. Don't be fooled by analyses of empathic words, right? empathy does not come from words, right? And now there's even this thing about fake AI therapists that are making recommendations to anorexic people to eat less, to not worry about cutting themselves. It's, the whole next wave of what we are going to be facing, what you are going to be seeing in clinic, right? It's completely crazy, right? This is from the paper yesterday, right? This is how fast this is unfolding, right? So I would just like to pause with all this in this question of, where does empathy come from? To cite my Zen teacher, this is Roshi Joan Halifax in Santa Fe, New Mexico. I mean, what she teaches is that empathy is something that is embodied, that you are able to experience because you possess a body. And when you see that picture of Jen, and something in that resonates, it actually resonates in your body and the affective parts of your brain. And that experience of empathy is what allows your cognition to process what that means to be having an experience like that. Because even if you haven't been her, you might have had an experience that's kind of like that, or you might have worked with a patient who's kind of like that, and your ability to simulate that within your own body is what creates that empathic moment. Roshi Joan would also say that what compassion is compassion is a response that comes from you emergently, that there is no formula for compassion. There is no thing you can say. There is no gesture you can always do. That compassion is a unique response in every moment to a unique situation between two people. And what characterizes it is the ability of the practitioner to remain focused and attentive, not be distracted, to allow that empathic process to happen, to work from a core set of ethical values, and to pause long enough to allow that moment to unfold, right? And so what this is saying, I think, is within us. There is a kind of belonging, a kind of community, a kind of expertise that is deeper than your personality, right? And how do I know that? Well, I know it from talking to patients who've received palliative care, who are receiving the kind of care that you give. And this is what they talk about. They don't talk about, having a lot of services. They don't talk about having the latest algorithm. What they talk about is they talk about feeling validated. They talk about feeling given back agency. They talk about feeling guided. They talk about developing a new identity that allows them to live well in the face of a serious illness, right? And so here's what they say. They say, illness is a thief. It came into my life uninvited. It took a lot from me. It left me in a place of devastation. This woman brought this image of the California wildfires as an example of how she felt after being diagnosed. I'm angry at my illness for what it has done to me. And palliative care and all the work that you do as communicators can flip that around, right? They choose to bring you into their lives. You help them recuperate mentally and physically. You put them in a place of stability and clarity, and you motivate them to continue forward, right? That is the real work that you are doing with the communication. It's not about getting code status seeds or signing these things or putting your, advanced care plan in Epic. What you're really doing is this, right? And of course, in Vital Talk, what we tried to do was set up a whole bunch of conditions to allow that to happen and allow you to build a foundation that you would not have to think about so much so that you can focus in on the real work. And actually, the web designer that I was working with at the time, he said, you should just put up the pictures of the people, because actually this is really about being a person and being yourself while you are being a doctor. And in fact, he was totally right, and we are still using portraits of our original group. And I just wanted to give a shout out to Dr. Kropp, who's actually one of our very first study subjects, right? Like, I know him from way back and have followed his career over the years, and really thrilled to see him as one of your community. The other way that I know that the internal part of you really matters is with some recent work that I have been doing with psilocybin for doctors and nurses with burnout and depression from their work during the pandemic. There were a lot of doctors and nurses who felt like, ooh, something has changed. There were cases that broke me, and I don't feel the same. And so we had a randomized study for those people. We did some psychotherapy. We gave them synthesized psilocybin, and this is what happened. This left panel is all the people who had placebos instead of psilocybin but had the therapy. The yellow lines, each line is an individual person who had psilocybin therapy. And you can see there's a pretty big difference in their symptoms of depression at day 28 after treatment. And these improvements persisted to 6 months. So the reason I'm mentioning it here, and I am not saying that you have to have psilocybin to be a good communicator, is that what happened here is we didn't change any of their external attributes. We didn't change anything about their environment. The only thing we changed was them. We changed how they felt internally about themselves. And actually, that had a huge lasting impression. So I just mean that to say that what you do with yourselves and what you do with your teams actually has tremendous value in how you yourself will persist through now what is a really difficult time. So